This conference will now be recorded.
In gynecology, we do several procedures on cervix. Cervix, as you know, that is the last part of the uterus, and it is like the outway of the passage out of the uterus and opens into the vagina. The importance is that it has to be closed so that a lady who is becoming pregnant, she will not be losing the contents due to gravity or some other problems. So basically, it should be able to hold the contents of the uterus. Then in the nulliparous also, it is not totally closed. This is a peritoneal opening to the exterior surface. It is lined by the endothelium, so it has an opening outwards. Very commonly, you are doing a procedure. You can see here also, we are holding the cervix. This patient has been draped, scrubbed, draped. Of course, should have been consented before the procedure. So now, the surgeon, is holding the cervix with the valcellum forceps. You can use anything, but when the uterus is non-pregnant, then it is, it has a lot of fibrous tissue, so it is very hard. So it should be held with some instrument which has teeth at the end, so that you will have a good grip. Then with the right hand, you can see this is the surgeon, this is the hand of the assistant, and this is also hand of the assistant. So you need to pull the posterior, introduce the speculum, can be viscous speculum, but there are a variety of speculum, can be self-retaining speculum. So anything whichsoever works for you, you should use that. And then the cervix is held with the valcellum forceps, and then this is the hand of the surgeon. Preferably, the surgeon should hold with both hands. So basically, what is done, it is pulled downwards and then upwards. Why? So that it will straighten the curved angle between the body of the uterus and the cervix. And then these dilators are introduced gently. We should not use force because this is tissue and you have to respect the tissue. Otherwise, we can damage the tissue and it can result in a lot of complications at the time of surgery, and then the patient will have consequences after the surgery also. For instance, during the surgery, you can damage the tissue. It can cause bleeding, and which will need fixation. Mostly, if the patient has bleeding during cervical procedures, we give compression, and by that, the bleeding should stop. In some instances, this simple compression will not work, and then you will have to repair it surgically, or you will have to thermocoagulate with diathermy. You have to be gentle because the suction cannula is the most common cause of causing cervical lacerations or the uterine perforations. And then number two, if this instrument, the Heger's dilators, they can cause the problem. So we will start with Heger's dilator number 1 can go up to Heger's 8, and then you have to write down your findings in the surgical notes also, operation notes also. Write down that what did you see on inspection. Things seemed fine. In the external genitalia, they appeared normal. Then you examined and then you carried out EUA with, and what were the findings of bimanual examination. These are very, very important because just by simple examination, you can tell the person, the examiner, that this is a case of miscarriage or this is something else. Even you can differentiate between the types of miscarriage. For the gynecological procedures, usually you have to dilate it. Okay, so you will start from number 1 and you can go to number 8. So here you can see Sims is here in the posterior one, in the posterior fornix, vaginal wall that is being retracted, and then the anterior lip of the cervix, it is done down with the valcellum forceps, and it is kept in this position by the left hand of the surgeon, and the dilator is used in the right hand of the surgeon. This is for the majority of the doctors who are right-handed like that. So you should know that how much force you need to apply here, and should be very gentle. Yeah. So usually, when do we need dilatation? When we are evacuating the band, this you are going to do this surgical termination of pregnancy, or you want to remove any foreign bodies like the intrauterine devices, or you want to treat some cervical polyps, or you want to remove some cervical fibroids. And we are going to do it before hysteroscopy also. So in some cases it may be required. Okay, that is one thing. So you should be familiar with that procedure. When we will talk about miscarriage, and then we will talk about the techniques. Then in your exam, they are always asking you that what type of cerclage should be applied. Sometimes the process can be there, right? So basically you can apply two types of cerclages. That is, you are going to apply at the level of internal os, and this is a very sophisticated surgical procedure. Never consider it a simple procedure. It is associated with high risk of complications and litigations. So we can basically use two methods, Shirodkar method and then McDonald's method. We will not go into the details that when we are going to apply it, there are specific indications, and we have already talked about that. We are not, just briefly, now we are not applying cerclages on the basis of history or on the basis of this only cervical length. You have to assess the patient. Okay? Now two things are important. Like patient is high risk because she has been having miscarriages, or she has this luteal phase defect, so we need to give her high dose progesterones. And then you have just done the examination and you have seen that the cervical length is less than 25 millimeter. So at 25 or less than 25, you are going to apply. Less than 25 millimeter, you are going to apply. So now they have to remove that classification that history indicated, but if you will see practically, these things are still valid. Okay? So the consultant is going to decide that who is going to benefit from it and who will not benefit from it. So patients are taken as accepted as day cases. They are guided about the procedure, and you have to tell them that applying this stitch can be associated with many complications. There can be bleeding, there can be infection later on, and then there can be accidental rupture of the membranes, which can start the process of miscarriage. So they are trying to prevent a preterm birth or miscarriage, and then the cerclage is causing many problems, and then the chain of events it will start. Basically, in your exam, they will ask you that what are different types of cervical stitches. So you should know there is a shortcut method. What do we do here? It is done under like GA mostly, but the type of anesthesia it is a patient will get, it is decided by the anesthetist. They are going to review the patient and then they can tell you. Preoperatively, it is better to give them prophylactic antibiotics. We know that if the duration of the procedure is less than 30 minutes, then we are not giving. But in this case, since the chance of having infection is very high, so better to give it to the patient. She is admitted. Once she is sleeping, EUA is done to see what is the location of cervix, and then also depends upon the previous history of the patient. You know, the cervical length should be between 2.25 to 40 millimeters. But if your patient has been having repeated surgeries like the many cesarean sections, then it will be taken up. And trust me, it's very hard to find such cervix because every time the healing is taking place by fibrosis, and this organ, it is also pulled up into the abdomen due to adhesions or due to just normal healing. So in that case, the advice would be that never use force, always seek assistance. Okay. So this process you're doing on the pregnant cervix, you have to handle it very carefully. So instead of, I hope you can appreciate it, instead of using the Valcellum forceps, you are going to use the tenaculum because single toothed and it is not going to be as traumatic as Valcellum. So you can use muslin tape. That is the best material which is used, and the safety profile has been established, so you are going to use that. So what we do here in the shortcut process, basically you should know exactly that what are you going to do in McDonald's method and in shortcut method. So here, as when the uterus has been, the cervix has been pulled up, and what you are going to do, you can, some people they like to do it with a Valcellum also. So it has been pulled down, but I have seen in practice that they are using tenaculum. In exam, they give you the option of Valcellum or tenaculum. You will have one of them will be there, both will not be there. Then you will click on Valcellum. A small incision, it is made in the interior fornix, okay, and an aneurysm needle or any small needle, it has been passed from the posterior incision around the cervix so that it point presents in the anterior wound. You can see here, right? It is going along this one from posterior to anterior. So when it is withdrawn through the posterior incision, one half of the cervix is circumnavigated by the ligature, and a similar maneuver is done on the other side. It will completely enclose the cervix in the ligature, which is then tied with the requisite degree of tension, and effectively it will close the incompetent cervix. So posterior to anterior, and then it is done, and we are tying the stuff, and then it is done on the other side. So basically you are closing the whole of this. What are we closing? The cervix. Okay, so the whole of this canal has been sutured. The second method, this is McDonald's, and it is if they ask you which process is better, then you should know that the outcome is the same for both. Okay, so it is easier, and then I will tell you about other benefits also. So what we do here, that you will just hold the cervix. You don't have to give an incision anteriorly or posteriorly, and you don't have to push the bladder up. Here, after opening the anterior wall, you have to push the bladder up a little bit so that cervix will be separated from the bladder. Okay, so but here this is a simple process, nothing is required. Again, muslin tape is used, and there should be good surgical exposure with adequate retraction. That is essential in both methods. If you cannot, because it's a tiny space, so you should have a good exposure so that you can see that. So different there are no specific recommendations that you should take 2-stitch or 3-stitch method. So sometimes you will see the consultants, they will just enter from here, go backwards, then again enter from this point, go up, and then close it. So that is the simplest technique, anterior to posterior, and then posterior to anterior, and then you are going to tie that one. Some consultants and some books, they have recommended that you should take 3 stitches, 3 bites, go from here, then come out, again go from here, and then come from here, and then you can tie them. So you can do any of these methods, okay? And then you have to write down clearly that how many stitches you have taken and at what position you have tied the knot. It is important, okay? And you have to make a simple diagram. You don't have to be an artist, just make simple diagrams so that everyone whosoever can look at the notes of the patient, they can see that what sort of stitch has been applied. Problem with the shortcut stitch is that at 36 to 37 weeks of pregnancy, again you have to give anesthesia to the patient. Mostly this is GA, and then it is removed because, as you know, that it is the bladder has been separated, so you have to go here and remove it carefully. So your patient will need another exposure to the GA. In cases your patient has been planned for a cesarean section, then you don't have to remove it, leave it in place, just do the cesarean section, and then you can, after the procedure, you can remove it abdominally. That's quite possible, no restriction on that. Sometimes the patients, they will plan to have another pregnancy, so in that case you can just leave it alone, just take the baby out through the cervical, through the uterus, and then leave rest of the things in place. It is this type of shortcut suture, it is not going to impair her menstruation or anything. It will not cause any obstruction. So the routine processes and everything is going to be the same, so no harm. But if you have to remove it, you have to remove it under GA. This one is removed at this McDonald. It can be removed at 37 weeks. And then for this, you don't need any general anesthesia or local anesthesia. Just relax your patient, catheterize the bladder, hold the cervix, and then remove this stitch. And after that, just observe the patient for a couple of hours. If she's not in labor, then let her go home and tell her that once she's in labor, she should come back. Both of these procedures, they are associated with certain risks. And the most common is the risk of bleeding at the time of surgery. Second, very rare, but it can occur. That is, we can accidentally rupture the membrane. So that's why we are consenting the patient. Later, what can happen? The patient can, initial complications mean anything which is occurring within 24 hours of intervention. So, trauma and bleeding, which are serious complications. Or always remember, if none of these complications have been given, then pick up the anesthetic complications, because patient can have develop any problem, any reaction to any drug, even to the anti-allergics. So this possibility should always be at the back of your mind. So then after 36, after 24 hours, the risk of infection, and then there can be secondary hemorrhage like any other procedure. So you need to treat that. And then in the later part, what complications can occur? There can be shortening of the cervix, and there can be cervical stenosis. So once you have done this procedure, you need to give 200 milligrams of NSAIDs. Mostly Indocid is given, which is also NSAID. It is given rectally, and then you need to give erythromycin to your patient, and you should give it for 5 days. Patient can be discharged home on the same day with follow up after 2 weeks. So what will you like to do before carrying out this procedure? You will like to see that fetal heart is positive and what is the exact duration of the gestation, because if you don't have full information, you cannot do that. So you should be fully sure that this is in the first trimester, or even it can be applied later, like after 17 weeks, like we talked about. Um, Rescue cerclage from 17 weeks to 27 weeks, it can be applied. So what are the further complications? If your patient has a miscarriage or a miscarriage, or she has like incomplete miscarriage, then what you will do? Then in cases of IUFT, if you have applied the this Shirodkar stitch, then it is a very important question, and it can increase the morbidity for the patient quite significantly. In that case, like they will tell you that there is IUFT at 18 weeks. You know that that is IUFT because patient is already in the second trimester. So you will call it embryo till the 8th week of pregnancy, and then after that it will become it will be a fetus like that. Then you will have to do posterior colposcopy. Okay, and then you can remove the stitch, like if you cannot stay open like this. If you can pass the section cannula and the miscarriage has occurred at an earlier age, then you can use the section cannula to remove the contents. And here this McDonald, anyhow you're going to remove it. Then regarding other procedures, what do you see here? What is this stuff? This is a colposcope, okay? It is done in also it is colposcopy is done as a day procedure. We will the guidelines have been changed a little bit, so we'll talk about that in detail because I want you to go through that document once, and then we can talk about it. So this is the colposcope. This colposcopy is done in the colposcopy clinic mostly, and this is a modern day one. Okay, so it has a mobile stand, so if you can rotate it and so that you can find the best place to see the cervix. Then these are the binoculars, and there is a light source and the movable light source and the movable arm. We are not using any irrigation or anything. So for this, you have to take just verbal consent of the patient. You don't have to do any extensive writing or anything. And this examination, it should ideally be undertaken in the absence of menstruation or indeed any vaginal bleeding or before any other gynecologic examination, which might potentially cause trauma to the cervix. What are the steps? The patient is, you have to consent the patient, can be verbal, can be because this is just a scopy, you're not going to do anything, but the consent should be there. A chaperone should be there, because in the absence of the chaperone, you cannot do anything. So the patient is placed in the left thoracic position. An appropriate sized speculum is carefully inserted into the vagina, taking care to avoid any trauma to the cervix. In situations where the vagina is lax or the patient is pregnant, the introduction of a latex glove over the speculum and the cutting of the end of the finger, it will assist the lateral retraction of the vaginal walls. Don't want to do excessive manipulation. After gentle swabbing to remove any mucus or blood, the cervix is inspected at low power magnification in order to assess its shape and size. evidence of laceration, and the presence of any overt abnormality. A cervical smear or endocervical swab, like this is for the infection screening, it may be taken at this stage. For a preliminary inspection of the cervix, some colposcopists they choose to apply a normal saline and then attempt to visualize the underlying blood vessels pattern by applying the green filter to the colposcopic lens. But this is not recommended. This is done by the experienced people, and once they are the consultants, then they can use whatever they want, that it is going to improve their efficiency or yield. We are concerned with this acetic acid. This is the common household vinegar also. Exactly the same that we are using at home. So application of 3 to 5% acetic acid. So the cervix is washed with an aqueous solution of 3 to 5% acetic acid, and then depending upon the strength used area of the aceto-white change, it may appear on the ectocervix within 15 to 20 seconds. Usually, there is a large swab, like we use something to, we are using this earbud stuff like that. We have similar thing, but it is a bit longer. So you are going to apply the acetic acid to the cervix, and after 15 to 20 seconds, it will show the changes. We call them aceto-white changes. So it will allow clear observation of the morphological details and the normal process of squamous metaplasia, as well as features of perhaps indicative of HPV infection or sometimes CIN. Here you can see that this is a small lightweight 3-chip CCD camera, and so it is attached to the colposcope. The acidic precipitates nucleoproteins. Acetic acid is going to precipitate nucleoproteins and abnormal epithelium. It may appear white. However, these changes are reversible and they will disappear with time. If the colposcopic examination it takes particularly long time, then additional acetic acid should be reapplied. Normal mature squamous epithelium, it will remain unaltered as opposed to metaplastic or abnormal epithelium, which will take up the dye and appear white. So which one is going to appear white? The diseased one or the healthier one? We should reply, okay? So normal, it will remain unaltered. And the metaplastic or abnormal epithelium, it will take up the dye and it will appear white. The density of the change, its duration, as well as the speed of uptake and disappearance, they directly relate to the severity of the CIN. You are often getting to seeing this one, that what happened, that Schiller's test was done. So what exactly is Schiller's test? Schiller's test is where a solution of iodine, which is also called Lugol iodine solution, it is applied to the cervix following the application of 3 to 5% acetic acid. This procedure allows a clear distinction between the normal mature squamous epithelium, which stains mahogany brown, and other types of epithelium, including immature squamous epithelium, abnormal CIN epithelium, and columnar epithelium, all of which they will tend to take up the iodine stain relatively poorly. Many colposcopists they consider that the application of Lugol's iodine it adds little value to the overall colposcopic impression. Positive iodine staining it can help differentiate normal from the abnormal, and also acts as a guide to ectocervical excision margins during the treatment. After examining the cervix, the vagina, and the vulva, they should be carefully inspected. The speculum is slowly removed under colposcopic vision so that epithelium of both the anterior and the posterior as well as the lateral wall of the vagina they can be visualized. Following completion of the examination, the colposcopic findings they should be carefully documented, and the final assessment should include a recording of colposcopic findings either by hand or through the saving of the digital images and annotation. As you know that everything is online, so and the image banks are there, so it is basically all images of the colposcopy, they are stored to the central data so that when you need to retrieve them, if you have access, you are working in that hospital, then you can do it. So the site of any colposcopically directed biopsies, they should be recorded. In addition, the type of transformation zone should be noted. So that is whether the upper limit of the transformation zone, can it be fully visualized or not. So that is the Schiller's test and the stuff. And these two forceps, they are basically used. Why we are using them? That if there is blood or there is mucus in the cervical canal, then we can remove them. So these are endocervical forceps. So sometimes they will simply give you an image and ask you that what is the name of this one. So this is the Desjardins. You can see that it has a longer tip. And this is the second one. This is the Kogan forceps. You can see that there are some teeth are here, so it is more bended. It is just like any routine stuff like that. So I hope that you can appreciate it. That it is just, it has just it has no curves and nothing, just simple stuff. So you can make it up that this is the Desjardins, because it is going to hold some foreign stuff and take it out. And this one is the Kogan, which has like some pointed edges, so you can see them, and it has some angulation at the handle also. Okay, then the transformation zone. What is the transformation zone? This is defined as the area which is enclosed between the original squamocolumnar junction at the innermost margin and the new squamocolumnar junction at its innermost aspect. As you know, the inner lining of the cervix, it is the same as rest of the uterus. So this is columnar epithelium. The external surface of the this one cervix, it has the same lining as that of the vagina. So that is going to be stratified squamous epithelium of non-cornified or non-keratinized variety. So where these two are meeting, we call that transformation zone. So this transformation zone, it keeps changing its place according to the activity of the woman. Like in the very young children, maybe you cannot visualize it, and once the hormonal changes will be there, then it will grow, and then you should be able to visualize them. Mostly when the malignancies and the other problems are taking place, then it is hidden inside, and then you won't be able to see that. In that case, what you can do is that you will have to take a larger biopsies from the transformation zone. We look at this picture, that what does it show? So as you can see that these are magnified images. So different types of cervical epithelium, like the original squamous and the original columnar epithelium, where they are meeting, that is the transformation zone. And then here you can see that if there is no demarcation between the two layers, it is not that much magnified. This is the columnar epithelium, and this is the like the newer squamocolumnar junction. So like you can see it, like I've told you, that it will keep changing depending upon the hormonal condition of the woman, like that. And here what you can see is, like, this is columnar epithelium, and if you will look, this is the size of the normal one, right? And look at this one, when it is undergoing hypertrophy or changes are taking place and they are significant, then you can see immature metaplasia at the outskirts. And a metaplasia is changing of one type of tissue to another one. So instead of being columnar, it can change to the cornified variety, non-cornified variety. So you will call that is a metaplastic change. Then here also you can see that this is cervical ectopic. Like this is because of the normal epithelial, normal hormonal changes. And what happens here is that columnar endocervical epithelium can be seen on the ectocervix. And this phenomenon is particularly common during puberty and in pregnancy, and it can be seen in the young women who are taking COCTs, because that is also like having the pseudo pregnancy. So it can undergo proliferation. So what we are going to see, more endocervical epithelium. Okay? So your patient can again present with irregular vaginal bleeding, or which can be due to contact or due to touch, and then you don't have to think about the infection first. So you have to see that, take the history, that what exactly the patient is doing, and then accordingly you can go further. So this is a physiological condition. This is not pathology and doesn't need any treatment. Once the patient will stop taking the COCPs, it will regress and go back to its original condition. Like that is the point. You don't need to remember its details. Okay. So if you look at this picture, it is the original place where, like, if slightly towards the, we cannot say that inside canal, but towards the inner surface, like you can see that this is the slit-like opening of the ectocervix. Okay, this is the original site of scamocolumnar junction. And then if you will see in number 2, here it is the scamocolumnar junction again. And then if you will see the third area, it encloses a shaded area that denotes where columnar epithelium it has extended onto the vaginal wall. That is the point. That is the when it is enlarged. So that was about transformation zone. Now punch biopsy. We are hearing and reading about this process of procedure all the time. So basically, what is a punch biopsy? You should reply. These things are important for you. So punch biopsy, this method is used to obtain small quantities of cervical tissue with little, if any, anesthetic required. Can be done without any anesthesia. So following biopsy, there may be a small amount of bleeding, which can usually be stopped using silver nitrate sticks. Or if it is persistent, then a small application of Monsell solution, it can be done to stop bleeding. Just remember these two things. Small lesions like a puncture, then you can just apply the silver nitrate sticks, and then but if the patient if this bleeding is not stopping, then your option is to use Monsell solution. It is commonly available in the ORs. Sometimes if the patient's bleeding is not stopping, then you will have to go for diathermy cauterization. And so rarely, the diathermy directed colposcopies, they may be performed under colposcopic guidance, which should therefore render a high degree of diagnostic accuracy. On some occasions, multiple biopsy may be required in order not to miss a high-grade lesion. There may be different types of biopsy instruments, and all of them, they are formed by a fixed arm and a mobile cutting part. That is because, it should be able to cut the tissue. So different examples can be there, like different tissues can be there. I will show you. Usually they will not ask you, you should just know that what are the indications and how we should do that. So when you want to take the biopsies of the lesions on the margins of the external os, the fixed part of the forceps, it should be introduced into the endocervical canal with the mobile part lying outside. And where more than one sample is required on both anterior and posterior lips of the cervix, the area within the posterior lip, it should be biopsied first in order to prevent problems with visualization of the lesions because of the bleeding, which can occur in the superior most biopsy site. So start from the posterior and go to the anterior. A single or multiple colposcopically directed punch biopsies, they may be required to confirm the diagnosis of a clinically visible, you can see here, the lesion should be clinically visible. So maybe this is, according to them, this is a ward. So anything is there which is causing bleeding, we need to do that. So complete excision of the transformation zone is not always required in every instance. For example, if there is a low-grade disease, just do the little punch biopsy, because low-grade disease, it is going to resolve on its own within 2 years. So that's all, the warts, they will look. Whitish areas can be there, acetowhite area, and warts like very small tissue. You have seen that they are also because of the HPV. But sometimes, like this is the whitish area, so it means that the patient is already having some precancerous problems here. So this is still not CIN, but some changes there. So one type of biopsy was punch biopsy. Now you are hearing this word cone biopsy all the time, and you're going to get questions on this process and this process and this procedure is related complications. So for most patients where the squamocolumnar junction is fully visible, so they may be treated with LASE procedure, large loop excision of transformation zone. However, there are a group of patients with significant intraepithelial abnormalities, and in whom, even with the careful colposcopic evaluation, the squamocolumnar junction is not fully visible. So when you cannot see it, always suspect that something serious is there. In particular, they will need to undergo some form of cone biopsy of the cervix. The objective of undertaking such a biopsy is to excise the entire transformation zone and any abnormal glandular epithelium so that comprehensive histological analysis it may be undertaken and excision margin status it should be determined. There are certain common indications for the bone biopsy, like we can go over them. If there is suspicion of microinvasive carcinoma or occult invasive carcinoma, if there is suspicion of high-grade glandular disease or incompletely visible transformation zone in women who have high-grade CIN, like CIN 2 and 3. For CIN 1, usually you are not doing anything. Then if there is significant disparity between cytology and colposcopy, then you will need tissue to make that final diagnosis. Positive endocervical excision margins, particularly in women over 50 years of age who have already undergone treatment of high-grade CIN. The potential morbidity of cone biopsy is such that the routine use of this procedure is to be avoided. If you're not going to do it on everyone, appropriate colposcopic assessment, together with the additional use of endocervical forceps, it may identify the upper limit of the transformation zone and hence allow the depth of excision to be excised to be tailored accordingly. Complete excision with clear margins, that is endocervical and the ectocervical, like clear margins, okay? It is regarded as adequate treatment. So this is not only diagnostic, this is therapeutic also. Keep that thing in mind, okay? For high-grade CIN, and also in cases of very early microinvasion of the cervix, like in the stage 1A1, cone biopsy is going to be effective treatment, especially where it is desirable to retain reproductive function. So here you can see that this is like the full process. You are like taking out the cervix. It is like a wedge. This is the cervix of the patient. It has been visualized, and then all around it we are going to take it. So how much of this should be taken? Like if you can visualize the cervix, then you know this cervix, this is like a cylinder which can be 25 millimeter to 440 millimeter. If you can visualize this transformation zone, this is the transformation zone, okay? But your patient has some high suspicion and there is diagnosis of CIN1, you are not going to treat it. CIN 2 and 3, you need to treat it. If the transformation zone is visible, take up this transformation zone and then 1 centimeter, go 1 centimeter above this transformation zone and take it out. I hope you can appreciate it that it is called a cone because we are taking out a cone shaped structure from here. We are not taking the whole this zone, we are just rotating the knife here and taking it out in the form of a cone. Okay? So 1 centimeter of this. So if you can see this transformation zone, you will take this point as a reference and go into the canal 1 centimeter above this point and take out whole of this tissue in the form of a cone. Triangular, cylindrical, but in the form of a cone structure. In some patients, you cannot visualize the transformation zone. In that case, where you suspected any change, you should go 2.5 centimeter or 25 millimeter above this point and remove the whole of the tissue. So that will be very large bone biopsy, and just you have to control the bleeding. Usually that extensive problem you are going to see in the women who have advanced cancer, who like advanced CIN2 or 3, or those who are like 50 plus years. So you don't have to apply anything here, like because you are not expecting that she is going to become pregnant and bone the tissue. So you want to avoid the, this recurrent miscarriage or cervical incontinence. That will not be the case. Now, for the last 20 or 30 years, the laser therapy or the laser procedure is done with a laser. So it can be used for vaporization of both the low and the high grade CIN. So that is also the same procedure. Okay, this is laser conization, essentially the same thing, but you are going to destroy the tissue. Any points, any questions, any confusion so far? Okay. So that's all you need to know about the cervical here, but you know that there can be cervical fibroids and we will have to remove them. So we'll talk about that later. Now, what about ovarian cysts? Ovarian cysts, they are common. Most of them are benign. If your patient is less than 50 years of, less than 40 years of age, then the chance of having malignancy in the ovarian cyst, it is less than 1 in 1000. If your patient is postmenopausal, then her risk is going to be 3 in 1000. Then the decision to remove the cyst or leave it behind, it depends upon several factors. First of all, the age of patient. Then what type of cyst you are expecting. This is mostly benign. Younger than 40, you're going to do all tumor markers like LDH, alpha fetoprotein, HCG, and CA125. Other antigens and LDH and other antigen tumor markers are not required in such cases. Okay, so you have found that these level of these markers is higher, so you are thinking that you should carry out benign ovarian cystectomy, then you can do it. Okay, and what about the size? Less than 5 centimeter, mostly those are functional cysts. What are the functional cysts? As you know, in each menstrual cycle, several Graafian follicles, they are recruited, and under the effect of estrogen and progesterone, and FSH is essential to recruit them, and estrogen is required for releasing this FSH. FSH is required for this, for recruiting the follicles. Okay, and when estrogen is produced, that is produced by the enlarging follicles also, it has a positive feedback effect. So more estrogen into the system, more stimulation of the anterior pituitary to release FSH, and then these follicles are going to increase in size also. Until a certain level is achieved, then after that, this estrogen, it will inhibit negative feedback mechanism, and the LH will be released towards the mid of the cycle. On day 12, you are going to see the maximum level of the LH, and then it will rise up. After that, there will be LH surge. And FSH level, it will start dropping because it has fulfilled its function. So LH level, there was a spike, and then what happened? Ovulation took place. Now the dominant follicle, it is going to release egg. So it will change into a corpus luteal cyst. This corpus luteal cyst, it is going to produce progesterone in the start. It will produce estrogen also. And if pregnancy occurs, then it is going to produce HCG. And it is going to maintain the placenta also. It is going to maintain the pregnancy. It will produce HCG, estrogen, progesterone. Now, what about the remaining follicles? They also enlarge a little bit, and some of them, they will rupture, and but that egg will not be of, this average. It won't be of the mentionable size. It will be very small, and sometimes they will not rupture at all. So these follicles, which were containing non-dominant follicle, they will change into follicular cyst or the functional cysts. If your patient has functional cysts and the size is like less than 5 centimeter, you don't have to do anything. Just give them combined oral contraceptive pills for 3 months, and they are likely to undergo regression. But sometimes they will enlarge. So, but you don't have to do anything for them. Now, the second type of the cyst. You know that there are different, the ovary, it contains a large variety of tissues. And that's why it can give rise to plenty of the tissues. Like there can be germ cell tumors. We'll talk about them in detail once we will go to the oncology section. So these germ cell tumors, they can produce different substances, and then some of the, we can see different type of ovarian cysts also. So incidence of germ cell tumors, it is low. And then the second type of cyst that you are going to see in the women of the reproductive age group, they can be like idiopathic, that you will have no clue that why they have formed. So if we look at the germ cell tumors, they can be, broadly, when you're talking about the ovarian cysts or the tumors in the women of reproductive age group, they can be epithelial or non-epithelial. And they're a different group of tumors like that. Can be benign, can be malignant. So the germ cell tumors, they are like 15 to 20% of all tumors, and malignant, germ cell tumors, they represent just 2 to 5% of the ovarian malignancies. Pathophysiology is different. We'll talk about them in detail. So basically, they can, the germ cell tumors, they can be differentiated, undifferentiated. Among the differentiated, like they can develop from the whole blastocyst. We call them embryonal carcinoma. You don't have to remember the number of each and every one. So embryonal carcinoma, then from the whole embryo, we can develop this teratoma. And then from the yolk sac, we can get yolk sac tumors. And then from the trophoblast, we can get the choriocarcinoma. Regarding the teratoma, the now common name is dermoid cyst. Can be mature, can be immature. Mature, that is benign. Immature, it has malignant potential. Then we can get undifferentiated tumors, germ cell tumors, which are dysgerminoma, and you can see that they are the most common germ cell tumors. Which one? Dysgerminoma. They account for 45% of the germ cell tumors. Then different hormones, they will produce different tumor markers. Like the dysgerminoma, it may or may not produce anything. If it is producing, maybe it will produce HCG or LDH. Immature teratoma, maybe it will produce alpha-fetoprotein and LDH, but sometimes there will be nothing at all. Yolk sac tumors, mostly they will produce alpha-fetoprotein because this protein is coming from the yolk sac. So this tumor is also called endodermal sinus tumor. Don't confuse them, that they both are the same thing. LDH may be or may not be elevated, but basically alpha-fetoprotein, it will be elevated. Choriocarcinoma, you are going to have HCG. So if your patient is having, we'll talk about them in detail later, but just I want to give you the background that when do we need to remove them. So these are the germ cell tumors. Then second type of tumors, sex cord stromal tumors. Among them, the most common one are granulosa cell tumors. When you see this GCT, which is producing estrogen, don't confuse it with other tumors, okay? That is, it is not an epithelial tumor. This is not a germ cell tumor. This is a sex cord tumor. So basically, when your patient is having teratoma, then you should know that this teratoma, it is pluripotent. It can develop any form of tissue. It can form anything like from teeth to hair. Then it can have ectopic pancreatic tissue, like you name it, any tissue in the body that can be found in the dermoid cyst or the tumors or the teratomas. Okay? So basically, you are going to diagnose such tumors on ultrasound. So benign ovarian cysts, how they should be removed. So the teratomas are there, then you have to remove them. Some people, they will say that if it is small, leave it behind. But the point is that it is never going to resolve on its own. So you have to do the surgery. That is the point. If the size of any cyst is less than 5 centimeters, it is found to be benign, like the tumor markers are negative, then you can just leave it, and what you are going to do, nothing. and reassure the patient. If the size is between 5 to 7 centimeter, then you have to see is your patient symptomatic, are tumor markers positive. Any of these things is positive, you need to remove it. More than 7 centimeter, of course, you have to do the surgery. Okay. And what are the complications of having such a mass? This mass can undergo torsion and it can cause severe pain in the patient. And the problem is that it can lead to wastage of the organ. So in that case, you will have to open the patient and then you will have to untwist it. As you know, for the ovarian torsion, the recommendations are like this, that just give the symptomatic treatment and cover your patient with antibiotics. Even if the tissue is turning purplish, just leave it behind unless there is clearly gangrenous tissue. Otherwise, you just don't have to do anything. Just cover with painkillers, antibiotics, and the patient is going to be fine. And just offer the follow-up ultrasound after 4 to 6 weeks. If your patient is fulfilling the criteria for ovarian cystectomy, then you should know that most of the procedures, they are laparoscopic nowadays. Laparotomy may be required for excessively large cysts, or it may be required in those patients where you are suspecting malignancy. In that case, you want to avoid intra-abdominal spillage. Okay? And if you are doing it laparoscopically, then you have to introduce a retrieval bag through the umbilicus so that the contents, they will come out of it easily and they will not be spreading to the peritoneal surfaces. At laparotomy, like if the tumor is big and or you are thinking that this ovarian cyst is large and it is showing features of malignancy, then you will have to carry out laparotomy. After opening the abdomen, inspect always all four of the surface of the interior of the abdominal cavity, under surface of the diaphragm and the liver and the spleen on the left side. Inspect all organs. That is your first step. You should identify the ovarian lesion, the ovarian cortex. It overlying the cyst is incised with a knife, or it can be done by the handheld diathermy to identify the plane between the ovarian cortex and the cyst capsule. This plane is developed using a combination of blunt and sharp dissections. If possible, then dissection is continued until the cyst is shelled out completely without rupturing it. Then diastothermy, it may also be used to ensure hemostasis. The resulting dead space, this is obliterated with an absorbable suture, and the cortex is reapproximated using a continuous fine non-absorbable suture, such as Prolene. Why do we do it? Because we want to minimize the risk of adhesion formation post-operatively. That is the point. And if this cyst ruptures, what you have to do is that just do proper cleaning. Okay, with a lot of fluid, you are just going to rinse the cavity and then you can proceed. So that is all about the ovarian cyst procedure that you can remove it. So going back to the uterine cavity, first we talked about the abdominal hysterectomy, the steps and the indications, and all of these things, they should be on your fingertips. You know, it is hard to put question on the surgical procedures in the actual exam, but they have many brilliant people who are making the questions, and they will definitely ask you the questions because they cannot test everything in the OSCE also. Okay? That is the point. This is what do you see here? Can you identify? You can say that this is a hysteroscopic visualization, okay? Because we are seeing the cavity from below. That is why you are seeing the walls. So, do you see anything here? What do you think? What is this? This is the cavity. What shadow is this one? This is endometrial polyp. This is not soft. This is not hard. It is soft. Okay. So it can be resected at the time of hysteroscopy. We have talked about it before, so we will not go into the details. Just twist it and pull it out. Usually it is not associated with any bleeding, but if it is associated with any bleeding, then you can apply diathermy like that. Then in the uterine cavity, you can see that this is Mirena, which has been displaced, so it can be just taken out hysteroscopically. Okay, that is the point. and this is the thread, like it is collecting here. What do you see in this picture? Fundus, lateral walls, and here are these are the fibroids. So fibroids, they are developing from the smooth muscle of the uterine cavity, but they can appear as de novo, like the new growths also. Important for you to know about the classification of the fibroids. 0, 1, and 2. What is the difference? You know, the exams are becoming more and more specific. They will ask you that patient has type 1 fibroid, submucous fibroid, so what are you going to do? So regarding the fibroids, the video and the lesson lecture notes, they are already available in the menstrual disorders or abnormal uterine bleeding or general gynecology. All three folders, they contain the same notes. So I expect that you will go there and you will read those notes, because it is very lengthy lecture, like maybe 4 or 6 hours long lecture, where we have discussed all menstrual disorders, and you should have a good knowledge of the subject. Type 0, peduncle, and the whole of the peduncle, this is the peduncle, okay? And the whole of the fibroid is projecting into the uterine cavity. This is the uterine cavity, which is triangular, okay? Type 1, this is submucosal fibroid, which is more than 50% of the fibroid. It is protruding into the cavity. So classification is not according to the basis that how much of it is present into the wall, embedding into the wall. It is on the basis that how much of it is obstructing or disturbing the uterine cavity. Type 1, this is submucosal fibroid, which is more than 50%, where the more than 50% of fibroid, it is into the cavity. Type 1. Then type 2, where the size of the fibroid is like this, that less than 50% of it is protruding into the uterine cavity. Don't think that this is the degree to which it is embedded into the wall. It is that just opposite, that how much of the fibroid is protruding into the cavity. 0, pedunculatum. 1, where more than 50% is obstructing the cavity, and type 2, where less than 50% is into the uterine cavity. So type 0 to 1, they may readily be treated, where they can be treated hysteroscopically, particularly if they are less than 5 centimeter in diameter. In principle, fibroids larger than this, they will either need to be shrunk by pre-treatment with gonadotropin releasing hormone analog, or they will be treated by open or laparoscopic myomectomy. In experienced hands, it is sometimes possible to safely treat larger fibroids, but this may need to be undertaken as a two-stage procedure. So the type 2 fibroids, they are potentially unsuitable for hysteroscopic resection, and they should only be dealt with by a very experienced hysteroscopic surgeon. So it is usually best to plan these cases as two-stage procedures. Like in the first stage, what are you doing? A visible fibroid is resected to below the level of the endometrium. A second stage procedure is then carried out 6 to 8 weeks later, and in most cases, the bulk of the residual fibroid, it will be extruded into the uterine cavity, and it will become essentially a type 1 fibroid, and which can be resected safely. Resection of type 2 fibroids. It carries an increased risk of uterine perforation, because this perforation, it can cause intra-abdominal organ damage, or it can lead to catastrophic vascular injury when using electrosurgical instruments. And fluid overload. Fluid overload, it has its own problem. It will cause hyponatremia. Your patient can go into shock, and then this fluid is going to retain in the body for some time. You'll be surprised that some of the fluids, they can stay into the body for up to 2 to 3 weeks. So you can understand that how they will affect the fluid and electrolyte balance of the patient. And then for these type 2 fibroids, you need an alternative surgical approach for these type of fibroids, so how they should be removed. So when we are talking about the different types of fibroids, this classification was that how much of that is obstructing the cavity. But if we'll talk about the fibroids in general, you know that they can be submucous, they can be intramural, they can be subserous, and then even inside the uterine cavity, they can be cervical, or they can be into the uterine cavity, they can be into the broad ligament. Broadly, if I will tell you about the treatment, submucous, and they are suitable for uterine artery embolization. If your patient has subserous, even that is going to respond to uterine artery embolization. Intramural, yes, they will also respond. But if your patient has a fibroid in the broad ligament, then uterine artery embolization is not going to be very helpful, because this fibroid is getting blood supply from the branches of the ovarian artery. Because in the broad ligament, there is anastomosis between the branches of the uterine artery and the ovarian artery. So that you will have to do surgery for that, and surgery can be quite challenging because they can bleed heavily. So then if we talk about the surgical procedures for fibroids, you can do laparoscopic procedures, and then you can do the open procedures. For the laparoscopic procedures, the size should be less than, the size should be like 3 centimeter. Um, Size can be more, but then the route. If it is less than 3 centimeter, then you can remove them laparoscopically. But like this book, this information is from Shaw's book. It says that up to 5 centimeter, it can be taken out. If your surgeon is an expert, then he can use, this. Um, they can just cut. They can use this resector, and they will cut the fibroid into many small segments as if they are shaving them off. And with resectoscope, they will be removing the tissue, and then they can thin it down, and then in the end, they will just burn the pedicle and take it out. But just now we have talked about it, that it should be done by the experts. Otherwise, we can perforate the wall of the uterus, and then it is associated with many complications. If the patient has huge fibroid or she has multiple fibroids, then you will have to take them out to the abdominal approach. If the fibroid is in the cervix, then it can simply be resected, or it can be shaven and then it can be removed. So still, this transabdominal myomectomy, it is done. And the other day when we were talking about the abdominal hysterectomy procedures, even then we noticed that hysterectomy was carried out because of the multiple fibroids. Like if a woman doesn't need fertility, then it can be taken out by the by the vaginal procedure. So instead of doing the myomectomy, you can do hysterectomies simply. Okay? This patient, she's having like a myoma is there in the center, but it is protruding. It is, and the size is less than 3 centimeters, so it can be taken out during vaginal hysterectomy. Whenever if they want you to identify the procedure, then you can always say that this is a reflector, and they are taking out the this fibroid. Bladder is reflected up, posterior wall is pulled back, and then this procedure is vaginal hysterectomy is done, and the fibroid will also come off through the same process like that. This is again vaginal hysterectomy for myomectomy, and if the fibroid is larger, then we will use the resector or morcellator, and then we will do this morcellation to reduce the size, and then it can be taken out. And the substance, it is held and then resected from the base, and then it is taken out. So that is a simple thing. This, you know about this, that this is the myomectomy screw, which is driven into the myoma, and then it is twisted, and then we take out the, and this fibroid. But as you know that you can use this instrument only during abdominal myomectomy. If your patient has like myomas in the broad round ligament of the, they can be in the broad ligament, they can be in the round ligament, or they can be cervical. In the broad ligament, you will go to the sides and you will open, and then you are going to apply this myomectomy clamp, paste it, and then you can remove it. If it is near this, this one is near the round ligament, so you will do open myomectomy, and you will apply Bonnie's myomectomy clamp, and then that is applied to the cervix, and then whole of the stuff, it can be taken out. Like you will take it and you will remove it like that. So this is open myomectomy, the abdominal procedure, and you have to avoid injury to the to the butt, to the surrounding structures and the blood vessel. Okay. And when you are applying this, this instrument, you are ligating the infundibulopelvic ligament, then virtually the chance of bleeding is going to be very less. Then in the abdomen, you will have to go for the open procedures. If the size of the fibroid is large or if there are multiple, you can see here. Okay. So then open procedures, and then you should know about the closed procedures. Among the closed procedures, I've told you that if it is pedunculated, just remove it hysteroscopically. So we call that whole process transcervical resection of the fibroid. And if you are doing abdominally, then you have to make a plan like it is in the posterior wall, then you have to cut it and then remove everything. So you have to, you must have read this point many times that there is fibroid. So how you are going to take out? So you are going to breach the wall. You are just incising the capsule, and then you are removing the whole of the. They call it enucleation. You are just taking out everything. Okay? Just you will open, remove the screw, and then again you are going to reconstruct the abdominal wall in 2 or 3 layers. Okay. Then another challenge can be that there can be bleeding from the wall, from the roof from where it was lying. Okay. So again, you can cut, and you will need to secure hemostasis. Dead space, you are going to close that by taking the sutures. So simply speaking about this process, what are you going to do? You are just reflecting the peritoneum, and the peritoneal flap, it has been pulled down. And what have you done? There may be like great difficulty in stripping the peritoneum from the front of the uterus, and separation is easier if the fibroid is immediately beneath the peritoneum, like subserous. The myometrium beneath the flap, it should be incised, and then you're putting the holding this flap, this fibroid, dissecting this myometrium, and then it can be taken out. This is called enucleation of the fibroid tumor from the uterus, and the fibroid is drawn up with friction using the one cell forceps, or you can use the myomas with this myomectomy screw. It's up to the surgeon, and this attachment to the myometrium of the this pseudo capsule. They are divided by sharp dissection with Mayo scissors. After that, you need to close that defect in 3 layers, and then we are going to close the peritoneum also, and you are going to restore the anatomy. Usually, if there is a large fibroid and you have like it was like multiple, and the dead space is there, then you can take the sutures in different ways. Like here, you are making a crisscross, like taking from here. Then the B another one, the same technique, and C another one, because you don't want, if you will leave this dead space, what will happen? Fluid will collect here. That is the point. So obliterate the space after enucleation of the fibroid. Now, if your patient had the cervical fibroid, you will give incision here up at the level where you can see the myoma. Okay? Listen to the lower part. So just excise that. You can make a V-shaped incision also, and then you can remove it. So even when you are doing the cervical myomectomy, you can see that procedure is essentially the same. You just excise the tissue on this fibroid, and then what you did, you enucleated this one, and after that you are going to remove the cervix. You have done this cervical myomectomy, and then you are going to close it. We bisected the uterus in the lower part, so you are going to close it. So such procedures, they are done by the experienced people, confined state, so there can be problem. Vaginal myomectomy, this route is very, very rarely adopted, and usually they say that if the size is less than 3 centimeters, then you can do it this process. Regarding the fibroids, you know that they can develop anywhere in the body. Okay? Like endometriosis, they can also develop anywhere, but mostly they will develop into the genital tract. So if they are into the vaginal wall, then you can still just open it and take it out. Here you can see that this is whenever you get a view like this, so it means that it has been removed laparoscopically. That is the point. Then again, this is laparoscopic myomectomy, and the fibroid is grasped with the 10 millimeter claw forceps, and through the left lateral port, and the normal this myometrial tissue, it lies anterior to the fibroid, and it has been dissected away. then in the end you will get something like that. Okay? So if we talk about the abdominal myomectomy, trans-abdominal myomectomy, so what we do it? So it depends that what is the size of the myoma. If the size of the fibroid is very large, then you have to give her, mostly, you will have to give gonadotropin releasing hormone analogs so that the size will shrink within like 2-3 weeks. The size can shrink from 40 to 70% depending upon the response of the patient. So the abdominal incision, this is decided like preoperatively, and consideration is given to the size of the uterus and the mobility. Sometimes you must have seen that there are so extensive fibroids that the uterus is just fixed against the posterior wall because everything is just packed over there. Then abdomen is open. So you have the option to take this phalansteal incision, but you will have to extend it. So mostly, this vertical incision is given because actually it will depend upon the size of the fibroid. So again, safe surgery techniques should be adopted, and you have opened the abdomen. After precautions, you are going to pack the intestine away because it should be out of the pelvis. So you need to minimize post-operative adhesion formation. So good technique and good techniques of microsurgery, they should be used. And why we want to do it? Because we want to minimize microscopic trauma to the peritoneal cavity, because whenever this peritoneum, peritoneum is very delicate, but whenever it is, injured, then there will be fibrosis and there can be severe response. So what you can do to prevent this adhesion formation, you can pack the bowel in the plastic bag. You can use the suction rather than the swab to keep the operative field clear of the blood. And you can do this, carry out this copious irrigation with normal saline, and this should be at normal temperature to keep the tissues moist. Then handle the tissue minimally, and it should be done as gently and as atraumatically as possible. Then we can use fine non-absorbable sutures to close the uterine serosa. These techniques are going to decrease the chance of adhesion formation. And one question you are always getting, that how you are going to prevent adhesion formation. You should be very clear about the pain in which you are going to incise. So then you should make a plan that how you can minimize the bleeding. Okay, so to minimize the bleeding, you can use like vasopressin can be used, and then sometimes the tourniquet can also be applied to the pedicle so that it will not bleed a lot, but you will do whichever is possible. Vasopressin, it has been used, and the results are the same. If you will apply this vasopressin, which can be given with adrenaline or can be given without adrenaline, and then the second thing is applying the tourniquet, but the results are going to be the same. Basically, the catch here is that why we want to remove this myoma, because irregular surface, and this is one of the causes of abnormal uterine bleeding. So your patient's hemoglobin will be low. So you need to build up this hemoglobin level before going for the procedure. And even if when there are multiple fibroids, don't plan to give multiple incisions. Try to remove as much of them through the single incision as possible. Okay? Mostly anterior incisions they are given. And what is the benefit? Because less chance of tubal adhesion or less chance of the ovarian adhesions, because you have to think about all aspects of the care. Then what you can do is like once the incision has been given and the fibroid has been seen, then the tissue plane should, in which between the myoma and the surrounding myometrium, it should be found. How you can see that? By inspection. If the MRI was done priorly, then again you can decide that where you are going to incise it. So when you are entering this plane, the myoma, it is shelled out easily using the blunt and combination of blunt and sharp dissection. So It can be done more effectively if the GnRH has been given. Without the capsule, it will become adherent to the fibroid. But when you are giving GnRH, it is not affecting this interface. It is not so like still you can demarcate that where is the fibroid and where is the myometrial tissue, and you can go between them, and you can use the sharp and the blunt techniques with equal ease. So once you have removed the fibroid, then again you are going to close the dead surface. Okay? Hemostatic sutures, they can be applied, and for hemostasis you are going to use absorbable sutures. Okay, just remember this point. For hemostatic sutures you will use absorbable sutures. On the external surface you are going to use non-absorbable sutures because they are associated with less tissue reaction and less fibrosis, less adhesion formation. So if you are closing the serosal surface, like this is the serosa, you will have to close it. So use something like Prolene and go in a continuous fashion, because and then the knots, they should be buried here. So tie the knot here and then start suturing it. Then a fine non-absorbable monofilament suture, it will reduce adhesion formations. And whenever you are completing any surgical procedure, you have to check with the scrub nurse that tell me about the counts. Counts are complete, needles are okay, like the number is fine, everything is safe, packs are there and they have counted, then you are going to close it. And then before cleaning, what you should do, before closing, you need to irrigate the tissue. Keep the tissues moist and then to avoid this adhesion formation. So if you pay attention, then you should remember that if you are giving a good uterine incision, then it will allow removal of most uterine myomas through single incision. Microsurgical techniques should be used because they are associated with less adhesion formation. Preoperative GnRH analogs can be used. Don't offer ulipristal acetate because of the chance of hepatic complications. Then the GnRH analogs, the other names can be gozerline, naftalene, leuprolide, and they are good for the preoperative management of fibroid. And a reduction in size, it will help you to modify your procedure and also modify the size of this incision also. There can be several questions. This procedure is associated with a lot of bleeding, so they can ask you how you can minimize the blood loss in the surgery. So blood loss during surgery, it can be reduced by preoperative GnRH analogs because they will cause softening of the fibroid and then they will make the removal of the fibroid easier. The problem is that if you are using GnRH analog, then we cannot separate the capsule easily. But rest of the fibroid, it can be taken out easily during this myomectomy. Use of GnRH before the surgery, it decreases the extent of endometriosis if they are pre-existing and the size of endometriomas, and then it will enable us to completely remove them even laparoscopically. That is if you're opening the uterus for the endometrioma. And then you have to do the irrigation and you will come out. That's all you need to do if you are going to do this myomectomy procedure. If you are planning to do like there is subserosal fibroid, you are going to use the same process and you can take it out easily. So regarding the instruments, you can use a variety of instruments, and like you can use the monopolar diathermy also to look at cut this and size this all of the tissue because it is associated with less bleeding. Okay, even when you have to excise that capsule of the fibroid, you can use the diathermy probe because you will give incision and you will remove it. Like all surgical procedures, myomectomy is also associated with complications. These are at number 1, hysterectomy. If your patient is bleeding heavily, you cannot arrest the bleeding, then you will have no other option. You will have to go for hysterectomy in view of hemorrhage. Hemorrhage, it is the most common complication of this surgical procedure. As you remember, I told you that we have to divide the complications which are intraoperative and then immediately post-operative period, which are the early complications if they will occur within first 24 hours. And if they occur after 24 hours, then these are going to be the late complications and they can occur up to like 6 weeks after surgery. Hemorrhage, which can be intraperitoneal or it can be intramyometrial. Hysterectomy, then the patient in the later periods, patient can develop post-myomectomy pyrexia. Patient can develop paralytic ileus because this is a long procedure going to take a lot of time, and there can be extensive handling of the intestine also, so it can result in lazy ileum or lazy gut. Post-operative region formations, then due to adhesions there can be small bowel obstruction, there can be bladder or urethric injury. It can lead to subfertility because there can be tubal damage or adhesions. You know, these things we are usually ignoring. We are just talking about the uterine cavity, but you should remember that when we are talking about the injury to the surrounding viscera, we have to talk about the tubes also, that they can be damaged, which can lead to infertility. So if this is again a catch-22 position, you are removing the fibroid because you want your patient to conceive, and at the same time we have damaged the tube. So handle the tissue very carefully. Then there can be endometriosis, and there can be adenomyosis. You can understand that the endometrial the tissue, it was damaged, it was left inside the wall or it went out of the wall of the uterus, so it can implant itself. So endometriosis can occur or adenomyosis can occur. The biggest issue that fibroids, they are going to reoccur. So we have to tell the patient that, well, if we have removed the fibroids once, it doesn't mean that this is a lifelong security from the fibroids. They can develop again. Then when you have breached the cavity, then this is a potential space for uterine rupture. So uterine rupture can occur in pregnancy. So that's why, you know, once you have breached the cavity, maybe the patient will tell you that she has undergone this cervical removal of the fibroid, but you should always insist on seeing the operation notes. And if they tell you that you have to plan a surgery, what will be your next step? Your step will be that that patient is you have to make a decision about the mode of delivery. So what you will do? Your answer should be, first of all, you will like to review the notes of that patient, that cavity was breached or not breached. Okay? Open myomectomy, there is a breach and huge one. You know, you have given a big incision into the uterine wall. So this patient is a candidate for cesarean section. So usually such cesarean sections, they have to be operated at an earlier gestational age. That is the point. Any questions related to myomectomy? Okay. Then when we talk about the abdominal surgical procedures, you should remember.
There is one question.
Yeah, please
Assalamu
go on.
alaikum. There is one question.
Walaikum salam. Yeah, please.
Ma'am,
Yeah.
usually which incision is better giving while removing myoma on the uterus? Is it vertical is better or transverse?
If your patient has like a very small fibroid, to begin with, if you are doing the abdominal surgery, then it means that fibroid was of significant size. Okay? Mostly for the large fibroids. By large, I mean that the fibroids, they were larger than like 7 centimeters, larger than 5 centimeters. So, you know, usually what they do is like this is the fundus. Okay. I have, trust me, I've seen them giving incision from anterior to posterior. So you can imagine that these incisions, they were like 20 centimeter long. Why? Because, you know, we planned the incision that we will give anteriorly in such cases where the fibroid is huge. Vertical incision is better because from the transverse
Okay.
you cannot take it out. So vertical incision is better, and about the vertical also you have to go from anterior to the posterior. Then you are resecting this tissue until the point that you know, the whole fibroid is visible. Okay, because you know, when you want to remove the pedicle, and even if you want to do it with diathermically, then you have to reach the root because you cannot do any process blindly. Then what are we doing? Then this, when you are repairing such tissues, then you are not doing like there would be a lot of tissue. So it is not simply closing the edges. Imagine like this one, and I've seen the seniors both in Ireland and the UK. They will, practically speaking, they are going to overlap the wall. They are not doing end-to-end closure. They will take this tissue and put this tissue behind this tissue. You get my point? Because they are reinforcing the posterior wall. So they are doing basically everything in their reach to close this wall as effectively as possible. So mostly they are overlapping it. Like I will tell you, like they will take lot of they will take lot of these purse string sutures here. That is the point. Okay, just going from here to here, going from here to here. Okay, that is the point. That so lot of suturing here. Like this will be like crinkled or the crumpled tissue, as if you have put some elastic tissue here, because they want the tissues to heal in all directions. But still, it is associated with a lot of bleeding and lot of stuff. Okay, so in the next pregnancy, so you have to tell them that they should that when they're contemplating a pregnancy, and then this cavity has been reached, then consultant led care, and usually between 35 to 36 weeks, you will have to give them the antenatal corticosteroids, and then you can just remove it. Then you can just give them the guidance that someone is asking, she was our old student, that are you talking about this part 2 questions? I said yes, like that. So that is the point. Okay, I want you to remember all of this information. This is super easy, it's not complicated, right? And then you should remember the incisions. Vertical incision is better, and that is the point. Okay, so we are going to start. So any other question related to this fibroid? Vertical incision, and that too, I used to get scared that why they have given such a big, huge incision. So you will have to do something, okay? So you will have to reinforce the wall. That is the point. Any other questions, please? You have to know about the myomectomy. The instruments are important when you're talking about the OSCE stuff, okay? But here in the written exam, they are going to ask you many things about the surgery, basically the types of fibroids, how you are going to remove them, and what complications you can have. Like all visceral injuries can be there. That is the point. Okay, ectopic pregnancy, you are going to find many questions on that on this one. So the same technique, different procedures you can do once you have. Okay, Dr. Rabia was there. Rabia, does it answer your question? You will give vertical incisions, and that too they can be like vertical
Thank you,
incision.
ma'am. You have answered my you have answered my question. Thank you very much.
No problem at all. So that is the point. Okay. So ectopic pregnancy lying outside the womb. You have the option to do self-injectomy and self-ingotomy. And the criteria, you are already familiar with that. That it can be like if the patient is hemodynamically stable, she is unsuitable for the medical treatment. Like the serum beta ICG is more than they say that more than 1500, you can give the methotrexate, but this one, her level is more than 3000. Usually when the level of beta ICG is more than 3000, then sometimes you will have to give them 2 doses of methotrexate. When you are giving 2 doses, then the cost is going to be the same as that of the laparoscopy. Okay, so then people usually they will go, because you are not going to finish the story and the story here that you have given them methotrexate. You have to do the follow-up also. So the cost of follow-up and the injections is going to be more than the this laparoscopic procedure. That's why then they will resort to laparoscopic procedures. The criteria that self-injectomy means that you are cutting the tube, so the patient is this patient is unstable hemodynamically, she has bleeding, and so you have no option. You are going to do the self-injectomy. The routine process, you are going to open the abdomen by the pen and still and the Joel Cohen technique. Both are okay. And then you are going to identify the tube, and you are going to see that what is the internal structure, how much blood you have removed, what is the condition of the internal viscera. Uterus is grasped and elevated, bringing the distended, distended fallopian tube into the view. Never touch anything, cut anything unless you are 100% sure that what you are cutting. That's why whenever you are going to OR, you should be fully fresh. And if you think that you are unable to work, ask someone else to help you or do that process for you. Okay? You will never take any risks because you are directly cutting that tissue, and it is very easy to cut them, but very hard to put them back in position like that. You will identify the mesosalpinx, that is the thin fold of peritoneum around the tube, fallopian tube. It is clamped, cut, and sutured in stages, keeping close to the tube, and the tube is excised. The pelvis is cleared of the blood, washed out, hemostasis, and check the abdomen counts, and then close it. So it is associated self-injectomy. It means that you have closed that tube and patient is not going to get any pregnancy in that tube. So sometimes they will tell you that first tube has already been removed and now you have the second tube and it is badly damaged. Badly damaged, just remove it. If the tube is intact, then you have different options. Then you can go for salpingotomy also. So the conservative surgical treatment, it may be employed for small, unruptured tubal pregnancies. So the most appropriate indication for this is when the contralateral tube is damaged or absent, like it was resected before. So then it has been suggested that subsequent intrauterine pregnancies, and there is higher rate if they are having something salpingotomy, then they can have the recurrent ectopic. The benefit is very small, and the risk of having this residual tube, it will still be there. And then when the tube is damaged even a little bit and you are doing and then again chances of developing ectopic, they will improve. So what you are doing, that on one side it is the tube is attached to the broad ligament, you know that one, right? It is carried into the upper femur border or margin of the this one broad ligament. So you will go to the upper end of the broad ligament, that is also called antemesenteric border, and then you can use the diathermy, that is even better, okay, and less traumatic. If you suspect that this is going to bleed heavily, then you can use vasopressin injection into the tube wall, and it will reduce the bleeding and it will prevent subsequent tubal damage, because no bleeding, no hurting, no excessive compression, no chance of trauma and adhesion formation. The trophoblastic tissue is extruded through the incision and the tubal bed is also irrigated. The tube can be repaired using a single layer of fine, again pay attention, non-absorbable suture. Why? Because it will cause less tissue reaction than the regular sutures than the absorbable suture material. So it will reduce the chances and incidence of having post-operative adhesions. Then wash the abdomen and close the hole of the tissue like that. So surgical treatment of ectopic pregnancy, it involves using open and laparoscopic techniques. Then the laparoscopic approach, it is associated with rapid recovery and less post-op adhesions. You know these things, but I keep revising them because you should know about them. You don't forget anything. Okay? And conservative surgical treatment, that is salpingotomy, it may be employed for small unruptured tissue, but the problem is that there can be another ectopic pregnancy, and sometimes you will have to give your patient methotrexate even after salpingotomy. Why? Because if there is persistent elevation of the serum beta ICG, then it means that some trophoblastic tissue has been left behind. Okay, let's talk about, so these were the abdominal incisions. Vaginal surgery, yes, we need to talk about that. In a sense, it means that the wound, it has opened up. Okay, this is the wound dehiscence. If you are talking about the uterine dehiscence, then you should remember that dehiscence means that the wall has opened up, the uterine wall, but still it is covered by the serosa. But once serosa of the uterine uterus, it has also been breached, it has opened, there is no serosa, that is called uterine rupture. So there is difference between them, the difference of only serosa. Now we are talking about the complications of the surgery. Bone dehiscence is one of them. It is just by the way, because if I will tell you that you will get 10 questions from the surgery, that will not be wrong. 10% of the questions will be on surgery. Then all of the questions, they're not going to be on the surgical procedure. Some questions, they will be about the consent, like 1/3 questions, 1/3 of the questions on the surgical procedures, and 1/3 on the post-op complications. Okay, so all of these things are important, but the good point is that you know about all of these things. So these are not new for you. This is just a repetition, just like a recall that you should remember these things also. Dehiscence, when the whole of the tissue is still covered by some membrane, something. Nothing has come out and the granulation tissue is covering, is on the sides. You can see that the wound has opened, but you didn't feel any viscera coming out of it. This is dehiscence. Evisceration means that all of this tissue has opened and now the intestine is coming out and it is coming out through this, and it is lying on the interior surface of the abdomen. Sometimes when you have this wound, this scar dehiscence, like the patients are always complaining about it, then you should not go and you should not go blindly. For such patients who have wound dehiscence, someone senior should go. What happens in practice is that we will just send the resident that go and evaluate her. I feel pity for the residents also, because they are very keen, they are learning, which is a remarkable thing. It's not easy to learn. But here we need some degree of skill. So at least someone senior should go. Wear a sterile glove, then clean the area, use this normal saline, then introduce your finger and swipe it along the borders. Many a times I have seen the gut adherent to that. It can happen. And sometimes when you will feel the tissue, the students, they will tell you that this is granulation tissue, but that is not granulation tissue, that is intestine. The reason is that why most commonly we will see the intestine, because this is a very mobile organ. Then it is like 6 meters long, a slippery surface, so it can come out easily. So be very careful and don't use any instrumentation, just blind finger. Okay, incidence of this abdominal wound dehiscence is 1% after elective lectotomy. After cesarean section, the incidence is much less than this one, but it happens. Like wound infection, how much? 5% of patients, they can have wound infection, but wound dehiscence less than 1%. Most common time to see it between 7 to 12 days post-operatively. There can be several causes, like the knot has broken. So, or make it a point whenever you are tying, the knot should be good, strong, and it should be in the proper position. If it is not tied properly, it can open up. Then there can be breaks in the ligature. Sometimes these can be expired or the quality will not be so good. Then if there is tearing of the tissue due to excessive tension or due to sutures which are placed close to the tissue edge. So we are just going to approximate the tissue. We are never going to pull it, and we do that and we pull that. We should not do that. Just approximate the tissue and leave it alone. Then these are the local causes. So secondly, the wound can rupture or open due to infections also. If I ask you that in which patients you have seen the wound dehiscence, scar dehiscence more commonly, you will say that in the older age group, because it can be due to comorbidities, or it may be due to the patient medicines which the patient is taking, like the steroids, and then the regenerating powers, they will also decline with the passage of time. Raised BMI. If you have to relate one most common factor of significant cause of wound dehiscence, that is going to be obesity. Raised intra-abdominal pressure, like patient had post-op vomiting, coughing, ileus. So address these issues aggressively. Nutritional deficiencies like lack of vitamin C. Why lack of vitamin C matters? Healing is by formation of connective tissue, right? This connective tissue is immature in the start. Okay? So what does the body produce? Body produces collagen. You know, collagen molecules, first they are produced as single molecules, then they will form helix, like three, these ropes, and then these three ropes they will tie together, and that is called tropocollagen. And then several fibers they will unite, and then this scar tissue is formed. For this formation of collagen tissue, vitamin C is essential. So you should include that vitamin C in your regular diet, like in the form of yellow citrus fruits, lemon, that is the simplest source. So vitamin C is required for healing. If someone is deficient in vitamin C, they are going to develop scurvy, but they are going to have this scar adhesions also, because the collagen tissue, it is not mature. In the initial 10 days after the surgery, this collagen tissue or the scar tissue, it will have just 20% of its strength. After like 80 days post surgery, the strength of the scar tissue will reach its maximum. Okay, 80 days. 80 days means 2 months and 20 days. So you can imagine that for how long your patient needs to take care. Scar wound strength will be maximum at day 80, after 80 days of the surgery, like that. So before that, the chance of this disease is higher. Then if there was ascites, patient developed jaundice, patient is anemic because blood is carrying oxygen and nutrients to the site. If there is less blood, then this process will be slowed down. Diabetes. Diabetes is going to affect this healing in several ways. Deficiency of insulin, and then tendency to get more infections. Adjuvant chemotherapy. I have seen patients who underwent this some surgical procedure because of this this malignancy. Then what happened? The surgeon, they did the surgery, and the chemotherapeutic agents they were given to her by the oncologist within the first month. It led to scar absence. That is one factor. Okay? Because the chemotherapeutic agents, they are going to kill the tissues, and here we have the growing tissue. Okay? So that's why we have to reconsider, and we have, if you're doing the surgery for the some cancerous procedure, you need to coordinate with the oncologist. Chronic pulmonary disease, because patient is going to cough, going to increase the intra-abdominal pressure. Then if emergency surgery was done, the chance of wound infection, wound dehiscence, both are higher if your patient had emergency surgical procedure. So how we can fix this problem? Like, we should correct if the patient has any risk factors, modify the weight, give them, as you know, that they have to undergo this diet and exercise regimes before surgery if it is not urgent. Then the second most suitable preventive step is that we should use deep retention sutures with non-absorbable suture material. So you will take deeper incisions, and as you know that you can offer mask closure. We talked about this in our previous sitting also, that mask closure should be done with non-reabsorbable suture, mostly PDS, which is mounted on a J-shaped needle. Mask closure of the abdomen. That is the most important step in preventing scar dehiscence in obese patient, and you must have seen that question in the recalls also. So then the wound healing, you're not going to close the wound very tightly, because it will increase the chance of ischemia and healing will be compromised. And the fatty subcutaneous fat, if it is less than 2 centimeters, just leave it alone. You don't have to suture it. So then early and late complications of the surgery. Early complications which are occurring, immediate complications will be occurring within 24 hours. Okay, and the early complications which are occurring in less than 36 hours. These are primary surgical hemorrhage, and the hemorrhage, it can be revealed, it can be concealed. So then the question arises how we can identify that. We will talk about it in our bio. Then superficial wound hematoma can form. There can be atelectasis. What is atelectasis? This is closure of a lobe of the lung. You know that there are many lobes and then one has collapsed. So there can be like that area which is collapsed. It will not participate in the gaseous exchange, and there can be infection also. Then there can be like if the ureter was damaged or bladder injury has occurred, it will become evident in 36 hours, like when there is surgical injury. Diathermal injury, it will become evident after 2 weeks. Then there can be obstruction of the ureter, wound infection, and mostly from the commensals like the streptococci. Then the fluid management is very important. Less fluid is going to the body is going into hypovolemia and then hypotension and other problems. They will arise, renal output will be less. Then pain management is very important. Whenever your patient has pain, you should pay a lot of attention, and then you need to give them suitable analgesia also. Regarding the late complications, then your patient can have all of these complications. Mostly they will occur in the 36 hours, but they can occur later also. Patient then after 36 hours, you should pay attention that your patient can develop UTI. There can be bowel injury, and now in the initial period, since patient was NPO, nothing happened. But the moment the patient started having the food and stuff, then she developed some other complications, like there was abdominal distension, something happened like that. Then thromboembolic events, they can occur. Then after 36 hours, if the patient can develop hemorrhage, yes, the answer is yes, patient can develop. And that will be a secondary hemorrhage. Patient can develop chest infection. Chest infection can appear in the form of pneumonia, in the form of bronchitis. Bowel obstruction can, even pneumonia can be there. Bowel obstruction can be there. Then paralytic ileus, diarrhea. Then abscess formation can also start at this stage, and then there can be even fistula formation, it can start. Then wound dehiscence and the incisional hernia, it can also occur after 36 hours. Primary hemorrhage, like we said, that it will occur within within 24 hours post-operatively. When we are talking about the primary hemorrhage, the definition is not going to change. Primary hemorrhage is that the patient has bleeding within 24 hours after the surgery. Okay, so that is not like if the definition is going to be the same, right? That patient is going to have bleeding from the wound within 24 hours, like that. That is the primary hemorrhage. So then you should know that how we can avoid it. This is if we talk about the common causes, it can be due to inadequate hemostasis, which was done intraoperatively, or it can be due to slipped ligatures. So that's why you are going to ligate the structures you are cutting. You have to ligate them doubly. First, go through the this tissue transfixation, and then there should be a loose dye around that. And make sure that you have closed everything properly. You must have seen in the recalls, what is the first step on entering the abdominal cavity? Inspection. What is the last step before closing the abdominal wall? Inspection of the pedicles. It's very important. So if the hemorrhage, is occurring after vaginal procedures or cervical surgery, then it is usually revealed because it will become evident. And then how you can stop it, that you will just pack the area and the patient is going to be fine by compression. So then you should remember that patient has already, she's in pain because she has just undergone a surgical procedure. So packing without anesthesia can be difficult, but we have to counsel the patient, give local, you can spray like that, and then we're going to pack it. Then if the primary hemorrhage is occurring after abdominal surgery or laparoscopic surgery, then it is basically because of internal bleeding. This bleeding can be under the rectus sheath, or it can be outside the rectus sheath. So we have to identify it. Okay? So if we talk about the signs and symptoms of primary hemorrhage, then patient can have a large variety of presentations. Like patient can have feel due to dyspnea, patient can feel lightheaded because she's losing blood. So then again, the patient can have present different with different signs like there can be tachycardia because body is losing blood, so the cardiovascular system is trying to compensate for it. So there will be tachycardia, tachypnea, hypotension, cold clammy skins, and then the patient will be less oriented also. That's why whenever you have a surgical patient, you have to start the modified early warning sign. That is the chart, you should initiate it. And if anything is abnormal, you should just pick it up. Secondary hemorrhage, as in cases of PPH, secondary hemorrhage is usually because of the infection, and usually it will occur after 7 to 14 days. And most commonly it is associated when you are doing the vaginal procedures, because that is exposed to a large variety of the organisms. That is the point. And like you have done this lace procedure, so even after that, even after cone biopsy, and then even after surgical management of the miscarriage, your patient can have endometritis. So secondary hemorrhage, it can also be due to incomplete evacuation, like they were like POCs, we didn't remove them well, so this problem occurred. If your patient has experienced massive hemorrhage, then she is at risk of developing DIC, or disseminated intravascular coagulation. Why it is happening? Because pro-coagulant factors, blood doesn't, remember it very clearly, blood doesn't carry coagulant factors in active form, otherwise the whole blood will clot. Pro-coagulants are there. Then when the bleeding is occurring, then some changes are taking place, and then these pro-coagulant factors, they are activated and they will form the activated coagulation factors. So hemorrhage is there, procoagulants are released into the circulation, and they will start this coagulation activity. So what will happen? Increased production and consumption of clotting factors, and then what will happen? Your patient will go into disseminated intravascular coagulation. You can diagnose that by elevated level of fibrin degradation products, raised fibrin soluble complexes, decreased fibrinogen level, decreased platelet counts, and prolongation of clotting time. Treatment of TIC, it means that we need to treat the underlying cause, like if there is hemorrhage or bleeding, we need to arrest that. And then if the patient has like deficiency of the clotting factors, then or the patient has like this clotting disorder, so that we have to exclude into the history. So now the patient has gone into DIC, so we need to give her fresh frozen plasma, which will contain the coagulation factors, most of the factors, not all of them. And you should remember that FFP is low in fibrinogen. And cryoprecipitate, it contains more antithrombin 3, and it contains more fibrinogen than the fresh frozen plasma. Coagulopathy, it will usually resolve in 24 to 48 hours. And if there is thrombocytopenia, then it should go away within a week. Then, that's how we need to treat it. And if we have any problems, then we need to call the hematologist. Don't forget to involve them. So then another issue like your patient is showing signs and symptoms of hypovolemia, so you need to correct it with fluids. Then you should remember one thing, that crystalloids and colloids, they are equally effective. Colloids are not more effective than the crystalloids in reducing mortality. So if your patient is bleeding and you don't have blood, in that case you should give crystalloids. And if you think that some blood vessel has been damaged, or the patient has like bleeding from some artery or from some venous tissue, then you should call the hematologist, or you can call then you need to call the interventional radiologist to go to stop this bleeding. Then another issue can be hematoma formation. Basically, hematoma means that a bruise or the collection of the blood under the skin. So management depends upon the presenting history, that what are the complaints. So then you should remember that most of the hematomas, they will go away with conservative management. So just give, this painkiller to the patient and carefully observe. Even giving antibiotics is not mandatory. If your patient has like hematoma which is not on the surface, it is beneath the wound somewhere, then how you will know that your patient has developed this hematoma? Patient will show spikes of temperature. So temperature will be going up and dropping, and then this will be your clue that this patient has developed hematoma which is undergoing sepsis now. In that case, you will have to give her antibiotics. Otherwise, antibiotics are not required at all. That is the point. Okay. Any question? Any problem so far?